In this video, I'm talking about multiple chronic condition patients. So this is a healthcare economics video. As a matter of fact, this is something that I researched that I'm very passionate about. And in particular, we're going to talk about why multiple chronic condition patients sort of get the short end of the stick in their healthcare, why we underinvest in research on these patients, and why it's pretty important that we invest more in understanding what's going on with these patients. And when I say important, I mean it's important both for patient health and also for the sustainability of the healthcare system. So first of all, who are multiple chronic condition patients? A chronic condition is something that you have for a long period of time, like diabetes, asthma, chronic depression, some types of cancer can be chronic conditions. And that's in opposition to acute conditions. Acute conditions, you get them, they're fixed, sometimes by the medical system, sometimes just by your own body, and then you move on and you no longer have them. So chronic conditions persist in your life. So people with multiple chronic conditions have, for example, diabetes and asthma and COPD and heart disease. They have a number of different things that they're contending with on a daily basis. And in this video, I'm going to be talking about why these particular patients receive suboptimal health care. So there's a number of reasons I'm going to go through, but the gist of it is, first of all, these patients are excluded from most medical research. Now think about that. Why are they excluded from medical research? Well, researchers want to narrow in on one particular condition and the effect of some kind of medical treatment on that condition. If you have patients in the mix that have a bunch of things wrong with them, it's much harder to isolate cause and effect. So these patients can muddy up your medical studies in a way that would make it really hard to do clean medical research. For that reason, when you're looking at patients who are optimal for these control trials, you're going to exclude these complex patients. And of course, our medical system is based on science, so if science excludes these patients, they're not going to have as big of a base of evidence-based medicine. Basically, they'll have evidence on one of their conditions, which was gathered in a very controlled setting on patients unlike themselves. And same thing for another one of their conditions. And there may not be good evidence about whether the medications for these two things conflict, about whether the treatments interact with each other in any way. And so most of the medicine practiced on them is sort of guess and check in terms of the way that their particular medical illnesses interact. Now, what about economics and sustainability of the medical system and all that stuff? Why should we care more about these patients than the other patients that we spend a lot of time researching? Well, 65% of all healthcare costs go toward multiple chronic condition patients, and 95% of Medicare dollars go toward multiple chronic condition patients. In which case, the fact that these patients are a much smaller share of the research that's done should worry us. So these patients make up a majority of medical spending, and yet they're a significant minority of the actual research that we do in medicine. That's starting to sound worrisome, right? So there's another factor that's going to really impact the quality of care that these patients receive. And that is the quality of coordination across different doctors. And let me tell you what I mean by that. For many of these patients, their chronic conditions would need a different specialist. You need an endocrinologist for your diabetes, you need a cardiologist for your heart conditions, you need a pulmonologist for your lung conditions like COPD or asthma. So that means that you need expertise from different doctors. And how well each doctor's recommendation plays in with the whole person care you're receiving is going to depend on how well these different doctors are communicating with each other about their recommendations for you, the different medications you're on, how complete each doctor's information is. For example, are your medical records, which were complete in your primary care doctor's office, do those transfer well to your cardiologist and pulmonologist? And in the United States, at least, we have a pretty fragmented healthcare system. So there's a good chance that your doctors are not talking with each other. They're not communicating about making sure your care is well-rounded or sort of makes sense from a bigger picture standpoint. It's like each doctor is looking at the trees, maybe a cluster of tree. Nobody necessarily is looking at the forest. And maybe your primary care doctor is supposed to look at the forest, but your primary care doctor may not have the medical expertise that your endocrinologist has. So is the endocrinologist's recommendations, does that mesh well with the cardiologist's recommendations? Well, you're depending on your primary care doctor to make that judgment call. But it's not guaranteed that your primary care doctor has the expertise to do that. Okay, so to summarize so far, we know that the majority of healthcare dollars go toward multiple chronic condition patients. And yet, the minority, the vast minority of medical research actually looks at these kinds of patients. They're excluded from most studies, and we don't have good scientific knowledge about the interactions between their different treatments. In addition to that, our system is not well set up for well-coordinated care. These patients tend to go from doctor to doctor to doctor, and whether or not anyone's looking at sort of the big picture of their care and sort of making sure that the treatments don't interact negatively, that may or may not happen depending on the quality of their primary care doctor. All right, well, that sounds a little bit bleak. So what is the hope for these patients? Could there be a way to serve these patients better in our healthcare system? Well, yeah, there's a few different ways. First, I'm going to talk about some things that exist in our current system, but are perhaps underutilized or underinvested in. And then I'd like to talk about some futuristic solutions that might help us better evolve the system to better treat these patients. Okay, so one thing we can do is to actually have meetings between these specialists. And some accountable care organizations do this. As a matter of fact, this is one of the things that the Affordable Care Act was trying to incentivize when it incentivized accountable care organizations. Because some groups, like the Mayo Clinic, for example, do have the different specialists talk to each other. They talk to each other to come up with a care plan that takes the different doctors' opinions into consideration. So it's a negotiation between the different doctors involved in a patient's care. And that at least has the potential to save money, because if you're doing a lot of care that's contradictory, that might conflict, that might put the patient in the hospital more often, it'd be better to just have a conversation between the doctors to avoid that. Now, one of the problems here, of course, is those meetings between doctors are very expensive. If you think about the opportunity cost of a doctor's time, and you've got, say, 5 doctors in the room because the patient has an oncologist, a cardiologist, a pulmonologist, and a psychiatrist, then that's sort of multiplying the per hour cost of deciding on this patient's care by 5. So if we're thinking about incentivizing the system to actually make this happen, the administrators are going to be asking, is the money saved from keeping the patient out of the hospital or reducing unnecessary treatments, does that outweigh the cost of getting these 5 doctors in a room together to coordinate care as a group? And it's not necessarily clear that that is fully incentivized, at least by the incentives set up by the Affordable Care Act. So needless to say, probably less of this kind of group meeting happens than would be optimal for these patients. All right, another solution that the current system has been trying to work out is just primary care homes or medical homes, which is just where your primary care doctor gets good at coordinating your care. They make the phone calls to your specialist, they get to know you as a person, and they just put in the extra time and effort to try to do a good job of coordinating your care. And when I say primary care doctor, there's different types of primary care doctors, of course. A gerontologist is a doctor who specializes in aging. So the elderly are much more likely to have these multiple chronic conditions. So if you have a doctor who has a lot of chronic condition patients, that doctor may get good at coordinating care across different doctors. So perhaps that's a skill they could develop. So that's one model, the medical home model. And there's lots of administrators all over the country who are trying to make that happen as we speak. Now, the third thing in our current system that is trying to do a better job for these multiple chronic condition patients is medical records. For example, if what really matters is having good transfer of information between the different doctors, that could at least potentially be done by a medical record system that does a really good job of transferring the right records to the right doctors. Now, medical record systems are pretty expensive, but certainly if they're done well, this could at least help with the coordination problem that these patients have. The other thing that medical record systems could potentially do is they could give us access to big data. And that big data might at least help us generate hypotheses about which treatments interact badly. Like, the medical research might not allow diabetes patients to participate in a COPD study. But if we have a database with a lot of patients who have those two conditions, that database could potentially be used to analyze which drug combinations seem to be associated with higher hospitalizations or higher negative outcomes of some type. And that would then give you a hypothesis that if you wanted to test that with patients who have COPD and diabetes, you could then develop controlled trial studies that include patients with those two chronic conditions. So now we're starting to move into the futuristic solutions to the problems that multiple chronic condition patients face. And this is where I want to talk about my own research a little bit. So right now I am working with students to develop a measurement of which patients need the most care coordination. So if you look at the scores of comorbidity, and comorbidity is it's related to chronic illnesses. It's basically your secondary illnesses that a patient has. For example, when they're admitted to the hospital, maybe you're admitted for a broken arm, but you also have diabetes and COPD. So those are your comorbidities alongside your primary diagnosis. The problem we have right now is most measures of comorbidity are looking at the death rate. And I mean, death rate is great. We need those measures. The Elixhauser measures, the Charlson Comorbidity Index, these do really important things for the medical research community when we're looking at complex patients. But death isn't the only thing that matters. The other things that matter include, like, how comprehensive is your care? How well suited is your care to your goals? How difficult is it for you as a patient to navigate the healthcare system? So I'm trying to develop a measure that asks the question, which patients need the most coordination of care? Like, which patients are likely to have 5 different doctors in different specialties? In which case we want to see what characteristics of healthcare systems do the best job at treating patients who need different medical specialties. So that's just a quick plug for my own research. But back to the main problem, which is, what are some futuristic solutions to multiple chronic condition patient issues? Well, the big data issue I think is real. I think if we can figure out how to collect big data sets and utilize them to study multiple chronic condition patients, that's key. But I think there's another possibility that we also need to start thinking about, especially since telemedicine is a bigger thing now that COVID's happened. So here's the general idea. The idea is, I think it would be helpful to have doctors who specialize in combinations of chronic conditions. So diabetes and COPD. There may not be too many doctors who specialize in those two things at the moment, but if a doctor said, you know what, the patients I'm going to encourage to come to my practice are going to be patients with diabetes, COPD, which is a lung condition, and osteoporosis. These would normally be treated by 3 different doctors with fairly distinct branches of medical knowledge. But imagine if there was a doctor who said, wait a second, I would like to specialize in the interaction between treatments of these 3 illnesses. So the patients I'm going to encourage to come to my office are going to be patients with exactly those 3 things. Now, of course, you're going to get a more complex set of patients. It's probably a small number of patients that have exactly those 3 things. But if this doctor were able to sort of pool patients who are very similar in their list of chronic illnesses, that doctor is going to develop intuitions about these patients that can then become hypotheses. And then you can take that doctor's hypotheses and test them using big data. And if those hypotheses seem to play out in the big data, that might be justification to actually do a controlled trial study on the interaction effects of the treatments of these 3 illnesses. It's hard to come up with a pool of patients who are that similar in their list of chronic illnesses. If you think about the number of illnesses and the number of possible combinations, it's just way too complex. Doctors are just going to end up getting a myriad of patients with a myriad of different interacting illnesses, and in which case they're not going to be able to recognize patterns. But if you have a cleaner set of patients that you're interacting with on a regular basis, if you're getting to know those patients on a more intimate basis, you as a doctor are going to have better hypotheses. So I do think this is one potential for telemedicine, that maybe you keep your primary care doctor if you like them, but if you have a set of 3 or 4 or 5 chronic conditions and you feel like your healthcare is very disjointed, where your different doctors aren't talking to each other, you're worried about interaction effects, you have side effects that you believe might come from these medicines or the interactions, it could be that you would like to log on and visit a doctor who's maybe across the country, but that doctor specializes in your 3 chronic conditions. I could see a market for that, and I could see that really improving healthcare and improving both health outcomes and healthcare costs by doing a better job of treating patients who need the most care. So this is just a bit of a diatribe of mine on the way our system fails multiple chronic condition patients. I hope you've found this helpful in terms of thinking about these patients and thinking about how our system could do a better job of treating them.